Dear Presidents, Manos and Yannis, thank you for the kind invitation to take part in that wonderful shoulder course that is going to cover almost everything about shoulder. So, RC pathology is wide range. Underlying mechanisms are divided into extrinsic factors and intrinsic factors. The first are the anatomic variables that compress tendons by bony impingement or a direct pressure from surrounding soft tissues. Intrinsic factors include tendon itself reasons, tensile overload, aging, microvascular supplies, or traumatism or degeneration. According NIR, 95% of the rotator cuff tears are initiated by an impingement event or impingement-associated lesion. The most common factors for that are acromial morphology, presence of spurs, morphology of coracoacromial ligament, presence of osteophytes to the AC ligament, and morphology of coracoid process. Os acromiale is pretty rare. Almost 8% of patients have an os acromiale. Generally, it is asymptomatic. If it is symptomatic, then the most frequent type is the mesoacromium os acromiale. Contraction of the ptoid tilt the mesoacromial os acromiale fragment forward and downward, this causing impairment to rotator cuff. The os acromiale, for that reason, doesn't cause a rotator cuff tear, but a tear may be associated with that, especially if it is symptomatic. Let's move to acromion. The hooked acromion is the most often associated with impingement and maybe with the rotator cuff tears. Acromial morphology has a predictive value to determine the success of conservative measurements and if it is a need for surgery. Overall, the successful of conservative management decreased with increasing acromial type. For that reason, acromion is a source of impingement, as we can see in that pictures. The killed acromion, according to Tucker and Snyder, this is a new type of acromial morphology. It refers to a central, longitudinal downward sloping spur of undersurface of the acromion. It looks like a cell killed. It is rare, almost only 1.2% on patients with rotator cuff tear. According to the authors, they found the killed acromion at 100% of that group with rotator cuff tear on the bursa side, and to 60% in patients with full thickness rotator cuff. Killed acromion is at least responsible for impairment and partially for initiate of rotator cuff tears. Let's move to the position of the acromion. This is the morphology of the acromion on the frontal plane. Excessive coverage of the shoulder joint by acromion is a risk factor, which can be assessed by critical shoulder angle, acromial index, and glenoid inclination. Critical shoulder angle has a range from 30 to 35 degrees. It is important if it is above 35 degrees, like in this case. This angle at above 35 degrees associated with rotator cuff tears, but degrees of critical shoulder angle is associated with primary concentric glenohumeral arthritis like this one. When we have a high critical shoulder angle above 35 degrees, then the stabilization of arm in the glenoid surface needs to increase the supraspinatus forces by 13 to 33% in each case. This induced supraspinatus overload. So higher critical shoulder angle, it is important also to postoperative prognosis. If we have a very high critical shoulder angle, like above 38 degrees, then we will have 40th fold increase the risk of full thickness retear after surgery. So this is a worse prognosis for rotator cuff repair. Let's move to acromion index. According to Neifeller studies, the average acromion index was 0.73 in patients with full thickness rotator cuff and 0.6 in patients with osteoarthritis. But in the control group, the general population, it was 0.64. Glenoid index is another index. The glenoid inclination is another index. The normal range is between 0 and 10 degrees. If we have, it is higher in patients with torn cuff, and it is also a bad prognosis factor for retear. If it is above 14, then the risk of retear is 15 times higher. So the acrohumeral distance and orientation of force vectors of the deltoid supraspinatus depend on the inclination of glenoid. Upward inclination decreases subacromial space, decreases the ascending force of deltoid, but increase the ascending force of supraspinatus. This means that a large acromion is going to overload the supraspinatus and maybe cause a rotator cuff tear. Short acromion, from the other side, is associated with high compressive force component, which means cause arthritis. Does acromion can tear the rotator cuff? Is a difficult question. Oral studies show that association between acromial morphology and the rotator cuff pathology is existing. Let's move to coracoacromial ligament. It is usual to see enthesophytes in that ligament, especially with type 3 acromion. Combination of enthesophytes and acromion morphology is particularly associated with subacromial impingement and maybe rotator cuff tears. We have different types of CA ligament, but in most studies, they conclude that all CA ligaments present with two predominant bands, anterolateral and posteromedial. The spur is more often in the anterolateral band, especially under the acromion. The anterolateral band is commonly involved to the impingement syndrome. Another debate issue. More studies are needed to determine whether variation of CA ligament morphology cause impingement or it is a function of it. Hand and egg question. Let's move to coracoid process. The pillar anatomy of coracoid process and effect on subacromial space are essential to understanding the concept of coracoid impingement. Impingement of coracoid of rotator cuff occurs between posterolateral coracoid and humeral head. There is a significant relationship between narrow of coracohumeral distance and subscapularis pathology. We recognize two types of coracoid process. The first one, the tip of the coracoid process, is in the inferior half of glenoid surface. This type is associated with supraspinatus tears. And the type 2 is the tip of the coracoid process is a superior half of a glenoid surface and associated with subscapularis tears. What about bursa? There is a study, or a couple of studies, that report that high levels of inflammatory process with cytokines enzymes produce a catabolic environment in the bursa of patients with with rotator cuff tears that increase the friction further. An increase in thickness of bursa, of subdeltoid bursa, can contribute to subacromial impingement. Another anatomical variation is subacromial plica. There is only one study also in literature with a lot of shoulders that found 60% of subacromial plica. I don't know how often, if it is so often. But subacromial plica may cause an impingement in young patients, especially where the secondary impingement due instability has been ruled out. And let's move to intrinsic factors. The most important is for us is microvascular supply. There is the critical zone is that exists. It's supposed to be a hypovascular area proximal to footprint of supraspinatus tendon. When the arm is full abduction, then the supraspinatus is compressed by humeral hand under the acromion, and reduce the perfusion may be significant. In that recent study, they performed real-time in vivo laser Doppler analysis, and they found that the lowest blood flow found at that point of footprint, not 1 centimeter or 1.5 distal from the footprint. That means that the critical zone of hypovascular medial maybe not exist. The total blood flow in the supraspinatus tendon was found significantly lower if there is a pathology of the tendon. So the lower vascularity of the tendon may be a secondary issue according to pathology. So thank you very much for your attention.